Our presentation this year at the 2018 SIOG annual conference is related to caregiver satisfaction as a result of a geriatric assessment intervention. The study was funded by the Patient-Centered Outcomes Research Institute and the National Cancer Institute at the University of Rochester, where I work and lead the program in geriatric oncology there. We're affiliated with a community oncology practice structure that's national called the NCI Community Oncology Research Program, or NCORE. And it's funded by the United States government through the National Institute on Health, and it allows us to do rigorous scientific randomized controlled studies in community oncology practices across the country in the United States. As we know, older patients with cancer commonly see their community oncologists and are more rarely going to academic centers. And so community oncologists are really faced with trying to develop treatment plans for not just older patients with cancer, but also their caregivers. Our research has shown that caregivers have high levels of distress in the care of older patients with cancer, and they also have their own comorbidities, physical problems, and emotional health issues. And yet, when they have an older patient with cancer, their loved one being diagnosed, that burden really falls on them. Although if you ask caregivers, they don't call caring for their loved one a burden. They want to help, and they want to really make sure that their loved one is getting the care they need. Many times, however, healthcare professionals neglect the needs of the caregiver. So what we did is we designed a large randomized study, which was what we call cluster randomized. The practice sites were randomized across this country. We had 31 practice sites that enrolled patients and caregivers. We were able to enroll 541 patients. These were older patients with cancer who were receiving treatment and in the community oncology practices. And had one problem on the geriatric assessment. As we know, geriatric assessment is a validated way to capture health, and we only enrolled patients who had problems on the geriatric assessment because we wanted to capture a more vulnerable patient population. In addition, the older patients were able to choose one caregiver, and we defined that we created the definition of caregiver using our patient stakeholder group scoreboard, which is led by Beverly Cannon in the United States. They helped us to define caregiver as a person aged 18 and over who was a friend and support person in the delivery of cancer care. So it didn't have to be someone really what we call caregiving in the house. It could be just someone the patient was relied on. The primary aim of the cluster randomized trial was looking at patient outcomes, so communication about age-related concerns, patient satisfaction, and patient function and quality of life. But we had secondary outcomes where we looked at caregiver satisfaction with communication. And we measured communication in a couple ways. We measured communication by audio recording the clinic visits and really counting up the number of aging-related discussions. The intervention was given to the physicians at the sites that were randomized to the intervention, and that intervention consisted of a geriatric assessment summary plus recommendations, and some of those recommendations included how to communicate with patients and caregivers, and also how to support caregivers in their in what they need. And so we audio recorded the visits, and we used that as one of our aims. And then we also asked on a survey called the Healthcare Climate Questionnaire about satisfaction. And what we're presenting today is that the geriatric assessment intervention not only improved or increased the number of age-related discussions and the quality of those discussions between physicians, oncologists, patients, and caregivers, but also increase patient satisfaction with that communication and increase caregiver satisfaction with communication. And caregiver satisfaction, the improvement persisted for 3 months after the intervention. So with the geriatric assessment, we were able to show that we're better able to provide patient and caregiver-centered care delivery. So rather than sort of not attending to the needs of patients and caregivers, the geriatric assessment allows oncologists to attend to more of their concerns, and patients and caregivers end up to be more satisfied with those clinical encounters. So that's a great question. So I think the geriatric assessment doesn't do enough for caregivers and even for supportive care. And I think we have to start to integrate palliative care models and supportive care models into the geriatric assessment and sort of combine the different disciplines. I also think there should be more dyadic approaches. So what dyadic means is partnering patients and caregivers together who receive the intervention together. And you're not just doing things for the patient and hoping the caregiver needs are addressed and the caregiver outcomes are improved, but you're doing things for both the patient and the caregiver at the same time and looking at outcomes over the same time. The reason why I think that is important is because how sick the patient is influences the caregiver, because the caregivers really want to help the patients they're caring for, and if a caregiver has nutritional problems or depression, then a patient has nutritional problems or depression that increases the caregiver depression and distress. And so we need to intervene on both the patient and the caregiver at the same time through our care delivery.